All right. Well, I'm going to get the show started tonight. Dr. Josh has been kind enough to let me drive tonight. Tonight we're doing something a little bit different. We're like Chris said, we're just doing one webinar this month. I do a intro webinar and Josh handles a master's webinar. And we just feel like everyone's super busy this month. It's the end of the school year. People are, dragging themselves to the finish line of school, and we've got AAPD coming up. And so we just thought instead of trying to do two of these, we would do one together, and we would do it a little bit different that would maybe speak to people who are, just wanting to get interested in these devices, or maybe somebody who already has them. So we put together what we're calling tonight the mashup. So this is going to be the mashup of advanced intraosseous delivery tonight. And if you saw the announcement that went out earlier on social media this week, Erin was kind enough to put a little social blurb together for us, and it was Josh and I on the advertisement, and then she did something in AI where she blended us together like a mashup of me and him, and it was just too weird. And I knew the rumors would be that Ian and Josh had a baby. So I said, please take this off of social media. We don't need any rumors going around, especially before AAPD gets here. So sorry y'all missed out on that, seeing what our baby, I guess, would have looked like, Josh, if we'd have had a baby. Next thing I want to talk about is we are going to talk about electric anesthesia tonight. But one thing that is super cool is that NuSmile Tech has gotten into the realm of scanners, and scanners they're coming for us as pediatric dentists. My husband's a general dentist. He has 4 scanners. He has a 3D printer. He's got all the cool, fun things. Adult dentists don't have sew-ins and sleeper ones, but they do have other cool things. And we're very fortunate that Casey Lynn is one of us. He is a pediatric dentist, and he teaches the webinars on the scanners. And I think that there is huge benefit to that. I would encourage everyone to watch that. And if you can't watch it, register for it anyways, and you'll get the emails with the links to watch it at a later time. So I would encourage you to, start learning something about scanners, because I do think they're going to be standard of care in pediatric dentistry sooner rather than later.
And can I say one quick thing? So
Yes.
I have the scanner in my practice now, and I really encourage everyone, if you're interested in scanning, to come see us at the APD. I'm going to hang out at the booth and just in the scanning area for a little while and talk about it. So it's easy to use, it's economical, and it's really amazing what it can do for your practice, just even in communication with parents. So it's definitely something to come look at.
Yes. And this is, to your point, we are all going to be in Denver. All the people you see on this webinar tonight are going to be in Denver. And we'd love to see you at the booth. There's actually 2 booths, 507 and 517. It's in the app. If you haven't downloaded the app to your phone yet for AAPD, please do that. What's really cool about AAPD is that I always hold off to buy from vendors at AAPD. 1, so I can thank them in person, but 2, that's where all the sales happen. So if you're, ask your team before you get to Denver, are you low on crowns? Are you low on materials? What are you low on, so that you can come to not only this booth, but other booths and get what you need materials and equipment wise. I'd like to flip it back to you, Chris, if you'd like to just say a little bit more about what doctors can expect at the NuSmile booth this year.
Yeah, absolutely. So I just posted a link in the chat to everybody. That is a registration link for the hands-on workshops that we're going to be doing in the booths during AAPD. So we'll have a Friday morning session, a Friday afternoon, Saturday morning, Saturday afternoon. They'll be broken up into a couple different topics. Sew-in and Sleeper 1 will be one of them. Dr. Ann and Dr. Josh will be leading a few of those. But you can register for those workshops, those hands-on workshops, via that link. If anybody doesn't get it or needs assistance, just obviously reach out to us afterwards. But spots are limited. We are getting pretty close to being sold out. We're hosting 8 people per session. The session is 45 minutes long. It'll be about a quick 20-minute intro presentation kind of topic, and then we'll spend the rest of the time hands-on with some chicken bones. But go ahead and register for that. Also want to mention that Dr. Solomon,
right? It's totally free.
It's free, completely
Okay.
free. Yes. Dr. Solomon will be leading the insight session with AAPD Friday morning. Y'all should have received a separate email from AAPD about that, but he'll be leading that lecture Friday morning. Immediately following that, we will have a completely open Q&A, hands-on inside the NuSmile booth to answer more questions about intraosseous anesthesia, SOAN, Sleeper One, etc. So hopefully we will see all of you there. Really looking forward to it. Big expectations for Denver. For those of you that were at Toronto last year, it's going to be a very similar format. So hopefully we'll see you all there.
Just going to say one quick thing. For all of you that have individual questions that we don't get to tonight, or if you just need help with something hands-on, with any of the NuSmile products, one of the things I actually just mostly hang out at the NuSmile booth that a lot of us do during the APD just to help. So I see like Brian Richards is on here. You know, he was gracious and spent most of his time too at the last APD. So we're all there to help. So if there's questions you've been asking, or you don't have one of these devices and you're a little nervous about getting one, come see us. We'll be, one of the KOLs will be there at all times, and we're happy to help you one-on-one.
Yeah, and KOL is not Kings of Leon. That's a key opinion leader. We're not in a band. We are key opinion leaders. It's kind of like an influencer, I guess. All right, Chris, I'm coming back. You ready? Can I go on?
All yours.
All right. So see us in Denver. For those of you who do not know me, a little bit about myself. I am a Florida State grad. I'm actually from Florida. I'm born and raised in Ocala. I went to Florida State with a biology degree. Then I went to Iowa and did dental school there. And then I did UT San Antonio. I don't even think it's called that anymore. I just lectured there a couple months ago. I think it's like UTSA now. But that is where I did my peds residency. Moved to Greenville, South Carolina. Should have put that on here. But I live in Greenville, South Carolina, and built a practice from the ground up, bought dirt and built a building. And I've been practicing in said building for over 25 years. That is shortly going to say 30 plus years, very shortly. And the reason that none of that really matters above what I've just said, the bottom line is the one that matters. I've made every mistake in the book as being a pediatric dentist and a business owner. And that is what I think gives people like Josh and I more street credibility with you on this call tonight, is that we've made mistakes. And that's why we're so passionate about talking about things like this, because this is something new that we can incorporate into our businesses and our practices and help our patients with. But we want to see y'all on a much shorter learning curve than we've been on with these devices and with other things inside of our practices. And this is my QR code here. If you want to, it's my Popple. If you want my information, if you want to reach out to me about anything, I taught Restore with NuSmile just a couple weeks ago in Chicago, and was walking around. Oh, let me help you with your space maintainer. Oh, let me help you. Are you in the pulp yet? And people were like, how do you schedule? How do you set goals? How do you incorporate the sewing into your practice? So, I mean, I will help you with anything. I'm like I said, I want you on a shorter learning curve than I've ever been on. And these are the people who I'm trying to keep on a shorter learning curve inside my bubble every single day. So this is Dr. Megan and Dr. Maria and Dr. Nash. And we run this bish is what we do. And I put this up here to say this, that we are a 4-doctor practice, soon to be a 5-doctor practice. And we see operative every single day, and we do 10 to 12 ops a day, and we only use these devices. We've only used these devices since November of 2023. There are no backup syringes in the drawer. And I am confident that if the 4 of us are not struggle busing it, parents aren't calling back with problems, we're not able to get into bone, we're not confident with getting patients numb, that we would hear about it. Our team, our assistants call operative patients after every single op. And I know that somebody would be in our ear telling us that, we're only getting 70% of the patients numb, or mom's upset about something. And moms are upset about stuff, don't get me wrong, but this is not one of the things that moms seem to be upset about right now. It takes a team. It's not just us four doctors. It takes a lot of education and communication with our team to get these messages across to parents that this is something different. This is something new, and parents a lot of times don't understand it. I remember Dr. Laree Johnson saying that she was injecting a patient, and the dad got pissed off and upset because he's like, "Why are you leaving that needle in my kid's mouth so long?" So there is some conversation that needs to take place on the front end of this and education. And so just remember, don't just start whipping these devices out and flinging them around in your patient's face if the parents don't really understand what's happening. And these are not the people that communicate to the parents. These are the people that I travel and take trips with. So I do own and run Holly Tree Pediatric Dentistry with Dr. Megan. She is my 50-50 business partner. And then I solely own the Tot Spot, which is a tongue tie and airway center. Have a light scalpel laser. Happy to talk to you about that outside of here. This is our building and our practice. My husband's a general dentist, met him in Iowa. He owns and runs one half of the building, and Megan and I have the other half, and then we run the Tot Spot out of there. Our building used to be this color. And as of this year, our building is now this color. We've given it quite the facelift. And we've also added a 4,500 square feet to it. So again, happy to talk to you about scaling and growing your business, what growth looks like, what growing pains look like. And I love it. I'm 56 and I'm just not slowing down.
Hey, that's me. Hi, everybody. Thank you so much, Ann. So my name is Josh Solomon. I'm a second generation pediatric dentist. So I've been in practice now 22 years, and I split my time. I would say I'm about 70% private practice, and then the other 30% is with teaching or traveling to lecture. I own the BioClear Pediatric Training Center. So I'm in the San Francisco Bay Area, and the whole purpose of my center is to bring restorative to a different level for pediatric dentists. You know, the problem is in our residencies, we just don't have time to learn how to do really good restorative that's aesthetic, that parents are asking for, and things like peg laterals or treating undersized teeth. You know, these advanced procedures really can take someone to go from even, to insurance-based practice to fee for service. And we're just not taught these things, right? I want all my teeth to look like teeth. I want to have radiographs where the contacts actually look like teeth. And that's something I'm really passionate about teaching. And I've now integrated the Sleeper One and SOAN in my practice. I have not picked up a standard syringe for, 11 months now. I couldn't even wrap my head around giving a block to a 4-year-old. That's what I did for 20 years. I couldn't even imagine doing it now. The way I describe it is like needing to numb a finger, but then you start at the elbow, right? And I've been involved with a lot of technology in dentistry, and I'm big on microscopes. I had digital sensors right when they came out. And I will tell you that the SOAN and Sleeper One has made more of an impact in my practice, I think, than anything else, maybe besides, switching over to digital x-ray. So that's a big deal. And then in my spare time, I also like teaching courses on, accounting and financial management of pediatric dental practices. But really where I spend most of my time is in that restorative life. And we can go to the next slide. Thanks. So that is my contact information, and you can do a scan there if you want to download an electronic card there. And my family, and I'm so happy I have all three of my girls home for the summer. And the child that I like the most, I'm just kidding, but that's my Charlotte, my bunny. And pediatricdds.com is my learning center. So if you want to find out about courses we teach, and I am super excited that for the first time, I'm going to be doing an on-the-road course with Dr. Bynum in her newly renovated and added to office. And so it'll be our very first one. We've got 20 plus of you coming out later in October. So I'm super excited to head out to South Carolina. We can go to the next. There we go. Just a couple of pictures of my practice. So I moved into a space about 6,000 square feet, and I have my learning center, and then also just where we see your patients. So during courses, we convert everything over to these learning stations and really try to teach everything hands-on in an actual pediatric dental practice. Chris, you're up.
Thank you. Thank you. We are going to launch a little poll here. Give me one sec. This will show up shortly. If everybody wouldn't mind answering these 4 questions, really simple. It's completely anonymous. We just want to take temperature of the room, see where everybody's at in this journey. New users, experienced users, non-users yet, and just really give Dr. Bynum and Dr. Solomon an idea of who they're talking to. Again, completely anonymous. So once we get some good participation, we'll go ahead and kind of go through these numbers, but appreciate everybody chiming in and answering those questions. Awesome. All right. So can y'all see the poll, Ann and Josh, or no?
Yes, we can.
Okay.
I can. Josh can't.
Can you?
I can.
Dr.
Yes,
Solomon,
I can.
You can? Okay, good.
Yeah,
so, yeah, looks like we got a good amount of SOAN users. Looks like a good amount of people who don't own the devices yet, so that's great. This is going to be a good combination of attendees. Exclusivity using the devices, it looks like majority occasionally fall back to their traditional syringe, which is good. This will be very helpful for you this evening. Have you tried using these devices by entering from the lingual instead of the buccal? Majority said no and or I don't own one yet. So we'll dive into that a little bit deeper. What is your delivery method preference? Drive, cruise, or not sure? Majority did pick drive over cruise, but majority says not sure. So we will cover that as well and dive a little bit deeper into that. So thanks again, everybody. Appreciate you answering those questions. Give it back to Dr. Bynum and Dr. Solomon.
Oh, this poll go away. Josh, why don't you talk about these products?
Sure. So I fall into, I graduated my residency in 2003. And so, I went to University of Texas, Houston, and NuSmile is based in Houston. So I've seen this unbelievable growth of NuSmile and the products they offer. And I can tell you that one of the reasons why that I've chosen to be so involved with NuSmile is they keep their finger to the pulse of pediatric dentistry. And if someone comes to NuSmile, a pediatric dentist, and they says, hey, what about MTA? What about stainless steel crowns? What about white colored crowns? What about white colored crowns on permanent teeth? It shows up. And so I really, I engage everybody, especially at the APD, come see the booths. When we hang out at the booths and we're there to help, we don't get paid for that. It comes out of the passion of us believing in these products and wanting to help all of you. So although we're going to talk about the SOAN and Sleeper One tonight, come talk to us about any of the products on here. I've placed a ton of BioFlex crowns, liners. I mean, every product on here I use on a daily basis. And trust me, there is more that's coming out. What's not on here, now we have NuSmile has varnish and SDF. And trust me, there's more products that are coming our way.
We got a little disclaimer here. Josh and I, unfortunately we do not own stock in NuSmile. Maybe we can arrange something on that, but this is just a disclaimer for that we are not Breaking Bad with by doing these webinars. Hit it, Josh.
One of the most important things about these devices is, number one, you can completely change the way that you deliver restorative care in your practice. We have to be careful with the words, pain-free or painless. But I will tell you, now as an advanced user, I wrote here 8 out of 10. I made this slide a while ago. I will tell you that 9 out of 10 of my patients, or 9.5 out of 10, literally do not react to the injection itself. Okay. And that takes a little bit of practice and it takes a little bit of training. And NuSmile has onboarding for you. You're going to learn some things tonight. But I promise you, you can take tears out of your practice. I used to do fair amount more sedation than I do now. All the time, I'll have a 2 and 3-year-old where I've got to extract ENF, and I would have done that with oral sedation or intranasal sedation, and I do that awake now. And they literally do not feel it. The case that really sold me that this was the technique I wanted to use to numb teeth was there on that lower right. This was a patient who was just scared as can be, and literally I gave one stage 1 injection where we numb just the soft tissue, and we'll talk about that tonight. And then I gave a half a carpule in one area right between O and P, and I was able to take all 4 of those lower incisors out. Patient did not react once. And one of the most important things is that was just a 1 injection into the bone. I did not have to give a palatal. I didn't have to give PDLs around here. And you want to just fast forward to all of them for me?
Yeah, sure.
Collateral numbness is one of the other amazing things about these devices. I never realized that often I may have a cooperative patient until you give an injection, and then, a minute later, they start becoming restless, they start having a tough time. And I don't think I realized how much that having a numb lip or tongue bothered a child, right? I mean, it sounds silly to say that, but now that I don't have any collateral numbness, I tell you, the behavior and the dentistry that I'm able to do has increased dramatically. And I can tell you without a shadow of doubt, I have never had collateral numbness. It's possible. We're going to talk about, techniques to make sure we don't get collateral numbness. But if you follow directions, you do all the steps, do not worry about having numb lips or numb tongues. And I'll talk about this later on. I let patients just eat and drink right away afterwards for most things. You don't have to worry about midlines anymore. So if you have a patient and you've scheduled RS and T for restorative and you've got time and now they're cooperative and you've got to do the other side, you can just do it. You don't have to give blocks anymore. You finish one side and guess what? As soon as you're done with that injection, they are immediately numb and you can start working. What does that do for our practices? That's fewer appointments. I have grouped patients, and Ann, I'm sure will tell you the same thing, is these appointments I used to do quadrants, now I do in groups. Right? If I want to do STKL, I'll do that all the time. I never would do that before. I never wanted to numb on both sides. And the patients are less stressed, the parents are less stressed. And I would say in the first month that I've got a sleeper one and so on, that this paid for itself. It really did. And the last thing, as far as those of you that are growing practices or have a big practice, if you want to grow it, is I've never had a tool that made parents as happy as these. When their child just does not react to the numbing and they're leaving happy and they don't have a big numb lip and they're not biting themselves afterwards, if you want to make a happy parent, that's the way to do it. Thank you. And that's the case I showed you there on the lower right. So this was stage 1. I just gave 1 injection there into the soft tissue. And then secondarily, 1 half carp intraosseous, all 4 of those teeth removed in 1 injection. Patient did not move, did not feel a thing. When we talk about this collateral numbness, it's funny, we don't really think about procedures in detail. We do them every day, but when we gave a block, right, or if you gave an infiltration, let's say, you've got to wait until that big bolus of fluid of that local anesthetic has to perfuse through the bone. Well, it doesn't go one way, it goes both ways. So if you're going to numb, let's say around A and B, you gave this big bolus of local anesthetic, and it's going to numb this way and it's going to numb this way, right? You're going to have your tooth numb in the soft tissue, but you're also going to get your lip numb. And since I've been using these devices, I have not had one case of collateral numbness. I haven't had a numb lip. I haven't had a numb tongue once. If that's happening to you, we're going to talk a little bit about this tonight. If that's happening to you, you need to talk to us and we'll explain to you why. It's usually because you're giving too much of that stage 1 when you numb the tissue. It can be positioned, but if you can imagine having a practice without numb lips or tongues, I promise you can have it tomorrow. The other thing that's super important for us to realize, because parents these days don't always accept what we say right away, right? And sometimes they are not as open to things as I would say as when I first started practice. The technique of intraosseous delivery of local anesthesia is not new, right? If you look here, this quote came from this book, and that was in the 1900s, right? And basically what this doctor was telling us is if you think about, I think about it as an orange, right? So the outside of that orange is your bone, and the inside is where your pulp or your inside the cancellous bone. And once you get past that rind and you go inside the orange, everything is numb. It's the same thing here with our jaws. Once you get that soft tissue, you pass through the osseous plate, that whole inner area of osseous tissue gets numb. And this is not new. What's new is digital anesthesia, and that's the big difference here. But again, I would not worry about this as being something new and something to worry about. And I'll talk about this a little bit later in one of my slides.
So this is not new. Like we keep saying it's new. It's really just new to the United States. These are all the countries. We're like so late to this party, y'all. These are all the countries. The colors don't mean anything, but these devices and this technology has been around for 20, 30, almost 40 years in other countries. So we are definitely late to the party. The reason behind that is because we just have the FDA and they just make everything super difficult, and they have their reasons because there's lots of bad actors in the space. But NuSmile and NuSmile Tech, they've been the ones, and Dental High Tech, they've been the ones to go to bat and to flush out what it would take to get these devices across the border and into our hands so that we can use them with our patients. So these are the two different devices. Well, this is actually just one we have up here. This is the sew-in. And Josh, I think you put this slide together just to kind of show what the device looks like and that this is the guide and how to use it.
Correct. So we often get asked about which device to buy. I have both in my office. Anne has both. If you are just going to buy one of these and move it around, the sew-in is the one that's portable. And if you talk to NuSmile, they'll kind of guide you on which device is best for you. But the nice thing is you don't have to, have one of these in each room. You can now, most people wind up buying additional units so they don't have to move around, but it's totally portable. You can take it with you, take it in one operatory, bring it in the next op. And in all the training that you're going to be given, not only the onboarding, but there's detailed instructions to tell you how much local to give, where to give it. So we don't leave you just trying to figure this out on your own. We'll hold your hand the entire time.
So basically what we're telling you is that you do not have to, and we hope you will not be using these traditional dental syringes, that this is something that has definitely evolved. Lots of things have changed and evolved in dentistry, not so much in pediatric dentistry, but this is a big one for us. I was on the call last night with somebody that's high up in dentistry, and we were talking, and I told him, I said, 3 things that have changed since I've been in my career that have changed my life are using a CO2 laser for frenectomies, having a IsoLite or a dry vac to isolate with, and this. These are the 3 things for me. This is definitely probably the top of that list. So this gives us the chance to rethink dental anesthesia. Josh, hit these for us.
So both devices are there. You can see the sew-in on top and the sleeper one that's on the bottom. And many people, it's really up to you as far as, there's pros and cons of each unit. Personally, actually the sleeper one on the bottom, that I have actually wired into my operatory. So we ran the power through. It's very clean the way it's set up. That unit is my preference. I just like the way I hold it in my hand. Now the business end's the same as both of these, right? And so if you have questions specifically about what unit, you should get, if you plan on moving around again, you're gonna get the sew-in. And this pedal does not need to be recharged, right? So this works on radio frequency, and this comes with everything that you need, including holder, a charging unit down here, and for the sleeper one, it comes with a mount, and I actually have this mounted directly into my chair, and it's a super clean setup. I literally have it right near my handpiece, and I go ahead and pick up my sleeper one, and when I put it down, I grab my handpiece. It's all right there and easy.
And this is kind of just showing those things as well. I have 3 sew-ins and I have 1 sleeper one. And the 5 behind it, just to give you some background on this, is the Sleeper 1 has been around in other countries for a long time. And so this is the 5th version, the 5th model of it. They've made some changes and upgrades to its look and its functionality. So that's why it's called the Sleeper 1 5. The Sew-In, this is the first version of the Sew-In. So eventually one day I'll be retired laying on a beach somewhere, but all y'all people on this call will probably be using a Sleeper or a Sew-In 2 and a Sew-In 3 and things like that. So this is what they look like. Like I said, I have 3 of the Sew-In, 1 of the Sleeper 1. I don't care. We have them stationed in all 4 treatment rooms. The pedals go with the unit. So if you are going to have more than 1 unit, we have labels on them. So we know which pedal goes with which unit in case somebody is moving and shuffling things around, which we don't really do that anymore. But I don't care. Whichever treatment room I need to go into to do treatment, I don't, it doesn't matter to me. They're both so easy to pick up, use, and understand. My preference is I don't like cords. I don't want cords laying everywhere. I wish if you've watched any of Josh's master classes, he shows how he has his Sleeper 1 mounted to his cart and to his unit, so the cord is well out of the way. I don't like cords. The other reason I don't like a cord is I don't want to drape that thing across a kid and he all of a sudden decides he doesn't like what I'm doing or she doesn't like what I'm doing and they reach up and jerk it out of my hand, and now we have bigger problems on our hands. So let's talk about what these cost. Let's just go ahead and get this out in the open at the beginning of the webinar tonight. Not too big of a price difference. The portable unit is $2,950 and the Sleeper 1 is $2,700. And obviously, if you buy them in bulk, you do get a good bit of a discount. So that is something you may want to consider if you're really thinking you want these, do the deal when you're in Denver next week. Chris, I was thinking one thing that I was thinking of another question for our poll later. I can't think of it right now, but it hit me right there. I want to ask another question of people when we're
one quick thing here. Someone had written in and asked about, we were talking about the wand earlier, right? And so the wand's a different piece of technology. It's not meant for intraosseous anesthesia, but cost-wise per use, the wand, I believe these days is about $4. And one question we get often is, well, once you buy this, what are the upkeep costs? And Chris, what's the breakdown on that on per use?
Per use, it's about 87 cents. 27 cents of that is the needle. The rest of it is estimate for anesthetic, time, sterilization, things like that. So when you account all of those aspects of it into it, it's about 87 cents per injection.
And I did a study in my first month when I got my units, and I think it took me 32 days for it to pay for itself with the amount of treatment that I added and be able to do immediate treatment. So yes, there's some cost to it, but I would really put that aside. I promise you that once you get it integrated, it's going to pay for itself. It may not be a month, it can maybe 2 months for you once you really just decide this is what you're going to use. But just being able to add extra treatment and being able to do more treatment that day, it'll pay for itself.
Chris, that's what I wanted you to add to the poll. I want to know who owns a unit and still has it in the box.
And who hasn't done their onboarding yet. Yeah.
Because Josh, how many times do we talk to people and they're like, yeah, I have it, but I haven't had the time to, I mean, we're all guilty of that, right? Like I bought a smart board in the beginning of the year. I have it set up. Have I taken 5 minutes to turn it on and figure out how it works? No, I haven't. I need to sit on a webinar for that, obviously. Okay, so back to what we're talking about tonight. What we really wanted to do is a mashup. We kind of, Josh and I sort of made a list, if you will, of things that we thought would speak to everybody tonight, wouldn't be over everybody's head, wouldn't be too elementary for people who don't have the units. And we just sort of picked and choose what we thought might interest you tonight so that we are doing something different, because the intro and the master's webinars, you can click on all of them. They're all very similar. You can watch them whenever you want. We just really felt like we wanted to get something different in front of you tonight.
Okay, so that I'm batting. One of the most common questions for someone that's new is they say, well, I'm having some pain while giving this stage 1. And for those of you that are new to this, the first stage, what we're doing is we're numbing the papillary triangle. We're numbing the soft tissue and the periosteum before we take that needle and penetrate through the cortical plate. You want to go to the next slide. So the tip here is that, literally and figuratively, is when I first started with these units, I would enter the papillary triangle. So if you think about the triangle, just right where that papilla is, I would enter that needle right in the middle. And the problem is as you're continuing to step on your small pedal and give that drop by drop initial anesthesia, it's very easy to get heavy handed and start to push distally, right? In this case, we're entering mesially, and we're moving distal. So start a little bit to the right of that midline, and that way you're going to stay away from the adjacent tooth. A lot of the pain that can be happening here is because you're injecting into the PDL. It's very easy to start giving drip, 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 and your hand starts to move just slightly. So you've got to have a good finger base, really stabilize that unit, and start just a little bit distally, and then you're going to make sure that just the papillary triangle is numb. If you're finding that you have blanching outside of that papillary triangle, that's one of the reasons why you're getting collateral anesthesia of a lip. That's typically every single time. If the doctor says, you know what, my patient's their lip is numb, you're probably giving too much in this first stage. So there's not an exact number or amount of local or time. I usually find it's 5 to 7 seconds, but we want to just see blanching in that papillary triangle, and then you're ready to change positions and give the second stage. Oh, you're on mute.
I muted myself because I'm doing this from outside tonight. I'm sitting on my back porch. The weather is finally nice. And who knew I'm in the pathway of airplanes? Like there's been massive planes go over my head already. So I'm going to kind of like pose some questions to you because these are things that get asked of me and asked of us. Teach me about the colored and blinking lights on the devices. The Sleeper 1.5 has 3 different colors on it. And the lights go around the handle of it, which I really like that. And that is what's different about the Soin. On the Soin, the light only talks to you on one side of the device. It's a 4-sided like square device, but the Sleeper 1.5 is round. So the light is talking to you and it's communicating with you. And if you're using it and you step on the pedal to change the different colors, you step on the top right side of the pedal, and when you turn the light blue, that's telling you, okay, the device is now set up to deliver an intraosseous injection. If you tap down on that pedal and you change it to pink, now you're telling the device, I want to give a different type of injection. I want to give an interligamental injection or some sort of a slower injection at this point, something into the PDL. And then you also can choose to use the orange, use it on the orange mode as well. And when we have it on here, this is like giving a traditional injection. This would be like using your traditional syringe. So that's the other thing. Let's say that you do want to punt and you're like, I just can't get into the bone. I'm struggling. I'm impatient. I don't feel like learning this new device today. Fine. Put this on orange and give an infiltration with it or give a block with it. You can do all of that. The devices will aspirate. So just don't, it does everything you could ever want it to do. The Soin, like I said, looks a little bit different. The lights talk to you a little bit differently. It's 4 flashing lights. And again, we've got, when it's blue, Aaron taught me this. This is a great way to remember it. Blue is for bone. So when we've got the blue light on, we know we're using it to give an intraosseous injection. And if we tap on the pedal and we change it over to pink, it's kind of a pink purple color. Everybody calls it something different. Now we're ready to use the device for an infiltration or an inferior alveolar injection if we so chose to do that, which I don't know why you'd want to ever do that, but you can do that if you just so choose. The other things that the light on the Soin does for us is it creeps up. It works its way up. And if this light is going, if you see this light blinking, you're like, okay, we are go for launch. We are administrating anesthetic at this point. This is when we're in the IO portion of the injection. If we see 2 lights start to blink, we're still go for launch. That means we're into the bone, and that means anesthetic is starting to perfuse through the pores of the bone and getting to the target or the nerve of the tooth. Once we start to see 3 lights blinking, it's time to pay a little bit more attention to what is going on. And what's happening is pressure is building up in that bone. Well, why is pressure building up in the bone? It's really a couple things. It could either be you've bent the needle and now you've like occluded the needle somehow. It could be you've got a piece of bone maybe in the needle, like a spicule in the needle, and now no anesthetic is flowing through the line. Or it could be that you are pushed so far up against bone that anesthetic can't even come out of the end of the needle. Or the other thing that can happen is it does come out at a specific rate, and maybe that rate is just too high to penetrate through the bone on that specific patient. So what I'm encouraging you to do when you see 3 lights blink, don't have an oh crap moment and pull the needle out and start all over. Just take a breath and sit with it for a minute. It's a very, very smart computer, and it will figure it out. It will slow down the rate. 9 times out of 10, it's going to slow down the rate and figure it out, and you'll see those 2 lights back down to 1 or 2. So just sit with it a minute. If it doesn't, let's say it keeps going up, then what I would tell you to do is I would tell you to just like back it up a little bit and see if you can back it off that bone, and maybe that's what the problem is. Because every time you take that out and go back in, not only are you damaging the tissue of the patient, but now you're damaging the integrity of the needle. So just, again, so much of how these devices work depends on patients, which is why I just laugh my head off that I'm teaching this, because I have 0 patients in any aspect of my life. So this is definitely, it was a very trying device for me when I first got it in my hands. So let's talk about what happens when we get to 4. Again, I would sit with it for a minute. I would watch and see if the device can figure it out. It is a very smart computer. It will probably slow the pressure, slow the cadence of anesthetic down to accommodate for the back pressure it's feeling. But if it gets to a point where you're still slamming on that pedal and maybe you're not paying attention, or I don't know what you're doing, but once it's blinking at 4 long enough and you haven't done something to correct the situation, the device can't fix the situation, it is going to shut itself down. So you're not going to sit there and just like blast pressure into the patient and have all the fluid come, backing out of the device. It will, if you don't fix it, it's going to fix itself.
And can you go back to your slide just for one quick second?
Probably.
One of the things that doctors sometimes will comment on is they said, well, this takes longer to give than a traditional injection. And the reason for that is because you're giving your local way too fast. There's no way by hand that you can give drop by drop anesthesia that these devices allow you to do, right? And one of the points here is if you start to see 3 blinking lights and you get worried and you come off your pedal, what happens is you're going to start the algorithm again for speed. So for those of you that already use these units and you've seen the instructions, they show you that there's an algorithm and it starts to go slowly. And then once the unit knows that it's safe, it's going to start speeding up the rate of delivery. Well, if you come off that pedal and reposition and you got it, and then go on the pedal again, you started that process over. So keep your foot on the pedal, just reposition. The other hint here is if you do have 4 blinking lights, and I will come out and I'll change my needle. If I think I need to come out and it's blocked, I used to wait a while, and I do agree with Ann, is we want to wait to see if and reposition a little bit. But if you have to think twice, take the needle off and put a new one on, it's just going to be faster. But again, keep your foot on that pedal. Don't take it off too early. The other thing is make sure foot position wise that you actually have your foot on the large pedal when you're giving the majority of your local. We talked to a doctor a couple weeks ago and she was saying, well, this is taking so long, and we found out she was just using the small pedal. She was just giving drop by drop anesthetic. No wonder it was taking 4 or 5 minutes to deliver. So just watch your foot position. So let's talk a little bit about local anesthetic. And we're not going to go into details of science here, but number 1, topical. That comes up a lot. I can tell you, I used topical maybe for the first 3 weeks, and it's because I was being a baby. I thought that it was going to help numb the patient, and I'll tell you what, is that I think it's actually a hindrance, because I just had a filling done for the first time in 10 years a couple months ago, and the worst part of the whole procedure was the topical, because it got in the back of my throat and it burned. It didn't feel good. I used topical, like I said, maybe for the first 3 weeks, And to this day now, since then, I do not use topical whatsoever. Once in a blue moon, if I have a really irritated tissue and have the unit and I'm in just PDL mode and I'm giving drop by drop just in the soft tissue and the tissue's infected, maybe that I'll use topical for that. Very rarely, but honestly, you don't need it. And would you say the same thing to you?
Yes. Yes, but I agree with your first line on this slide. When you're learning the devices, don't do anything different. It's like running your first 5K. Like, do everything you did in the training that do all the same thing you're going to do on race day that you did in your training. So don't change anything up. Just do absolutely everything the same until you master the devices.
And I did have one or two experiences where we had a parent question why we're using topical. So you may want to have your teams have a little discussion when you first bring these in of what to say to parents. And I'll talk about that in a different slide. But again, we just don't need it. There's two main local anesthetics that we use in pediatric dentistry. And for these devices, we're using articaine. That's it. We won't go into the reasons why, but the main thing is it's more soluble, right? That it works faster, and speed is important here. And the nice thing is that our articaine, it is hydrolyzed in the plasma, so the breakdown of this product is faster. It doesn't have to hit the liver first. You will find you're going to use far less local than you ever have. If you think about it, when you gave an infiltration, you had to give a big bolus of solution there to get all the way through the bone, all the way to the apex. You just don't need that anymore. We're passing that golden rope. We can go to the next slide there. So which anesthetic do we use? We're going to be using articaine primarily. I've never actually even used lidocaine in these devices whatsoever. We can go to the next slide. One of the important points here, we can pass through this and just bring them all up. I want to point out to you the working times of the local. There's some doctors, and this has been posted a lot. They said, well, you know what? My patient had pain when they were checking out with the front desk. And I will tell you that your patients had pain post-extraction or whatever procedure you're doing. It was geographical success, because by the time things started bothering them, they're either in the car on the way to school or at school or they're at home. So the working time is shorter. I see that as a positive here. A vast majority of the time in my practice, I'm using 1 to 200,000. I want to make it easy for everyone and just give you my quick rule is most of the time I'm using 1 to 200,000. Okay. The only time that I'm switching to 1 to 100,000 is for extractions, especially if it is if it's a hot tooth and I'm really worried about keeping the tooth numb as long as possible and coalescing and keeping as much solution in one area, then I'll use 1 to 100. But vast majority of the time, it's 1 to 200 every single time. Anne, are you the same way in your offices?
Yeah, I don't even have any 1 to 100, actually. We have all 1 to 200. And all of our ops are 30 minutes long in our practice anyways. But let's say you do run over or for some reason you don't have enough anesthetic on board, go in and give some more. And the reason I do it, Josh, is I've got 17 dental assistants and I just don't want them loading the wrong stuff. I'm just trying to keep it simple, stupid.
Right. No, I understand. Another point here is if you're worried about your local wearing off, like post-extraction, you can, at the end of the appointment, give them a little bit more local, or that may be a time where I'll do like stage 1 and just go around the papilla and maybe give a little bit more local there, just on board as they're leaving, just so they're comfortable. What this has also taught me is if I have a procedure that I think that's going to be painful for my patient, I'm now preloading them with Motrin or Tylenol. I'm just telling parents, we give it here or I have them give it at home, because things are going to be sore afterwards, right? It's just these wear off a little bit faster. But again, I think that's a great thing. That's a great thing. Next slide for me. Yeah.
One question we get asked is, why is it so slow? People think this is completely wrecking their day and wrecking their schedule. And this portion of the appointment is much slower, but the appointment itself goes so much quicker. And the devices on average will deliver 1 milliliter of solution every minute. So 1.8 cc's in a carpule, we're looking at about 2 minutes. But we talked about it already, that if it comes up against some resistance, it's going to slow itself down. If you take your foot off the pedal, it's going to change the cadence and take longer because it's going to have to ramp itself back up. But on average, to deliver a full carpule, you're looking at 2 minutes. Most of the patients I'm seeing are getting a quarter carpule to a half a carpule per quadrant. So I'm not even pushing a 2 minute mark. It just feels really long. It's like half of a Frozen song in our office. And I'm just sitting there staring around, singing Frozen with my patient while this is happening. This is Dr. Megan seeing a patient, and just going to let you see for yourself. We've got this on speed here. Gonna numb in between these front teeth. Looks like something's about to go to the tooth fairy shortly. Yeah, and this is the typical face of a kid. Like, they don't care. They just don't care. You just tell them you're taking their temperature and they just don't care. It's going to prep a tooth. Finish it. Getting a couple of those guys out of there. Thumbs up. 7.5 minutes. We schedule 30-minute ops. If you're done with that kid in 7.5 minutes, you do your post-op with the parent, you get the room turned around. I now have 20 minutes left that I can pull a recall off the clinic floor and bring into this room and do same day treatment. And this is what sockets look like. Typically, this is what sockets look like. Can't get into the science. I don't want to get in the science, but they just don't ooze. You don't have a lot of blood. It really is a very, it creates a lot of hemostasis. And this is what typical sockets look like after you take teeth out. Here's another kiddo. This is Dr. Nash's patient. This is his first premolar, that adult tooth that he's taking out. So he was a little puckered about the situation. So he did numb on both sides of the tooth, more for himself than for what, you don't have to do that. But he was a little nervous taking out his first adult tooth, and he's taken out plenty of adult teeth. He took out actually took out a hot permanent molar recently. And it's out. Here's our patient telling us it was great. And that was less than 7 minutes. So I think that just debunks the whole myth that this is making appointments take longer, because it just doesn't. And let's say that you numb the patient and you're like, holy crap, I have to go check 4 recalls. Fine, go check your 4 recalls and come back and finish the treatment. The patient is still numb. It's not that you have to stay in the room and do the treatment, but now you have the option to stay in the room. Here's another little kid. It sucks when we have to do this with these little ones like this. It breaks our hearts, and it's so much more compassionate. I mean, they're going to cry the whole time. I think it's worse if you numb them traditionally, and then like you set them up and you have to wait like 4 or 5 minutes for them to numb up, and then you have to lean them back in the chair, and they're like, holy crap, we have to do this again. So I do feel like it's way more compassionate to just go ahead, have the patient in the chair, numb, do the thing we have to do. Two minutes.
And can you go back to where that she's holding the sew in there? Yeah, just a bit of in that video. I just want to point out hand position here. This is about as perfect as it gets. One of the most common questions we get is about bending needles. And the reason for that is if you hold the device at the cartridge, the plastic container that's holding your local, if you hold it away from the business end of the needle, you're going to torque, right? So if you see she's got two things perfectly here. Number one, we've got a good finger rest, right? So our index or middle finger is resting on the teeth itself. And then we're grasping that pen grip literally right at where the needle meets the cartridge. If you do that, you're going to be able to direct those forces straight down without directing and moving. It's very normal to bend needles, and don't worry about if you're bending needles. You guys, I did a bunch for the first couple of weeks. That will go away and you'll rarely bend a needle. But that's the position I want you to see right there. That's perfect. It's safe. Even if that little one moves, that needle's not going anywhere. And they're able to just to give forces straight down instead of pushing and torquing. All right, palatal access. So I always thank Eric Hans, my good friend, for teaching me this. And, we learned in school as pediatric dentists to stay away from the palate, right? We don't want to give anything that has to do with the palate because it's so painful. And I will tell you that these days I do this all the time. I'm probably, I would say maybe 2 to 1, where that 30% and 33% of the time I'm using palatal access. One, and I said, don't be a baby. You got to get this out of your head that it's going to hurt the patient. They're going to feel the same whether it's buccal or it's palatal or lingual, either way. Especially if you have a big abscess, right? We know that infection is going to drain to the path of least resistance, which most of the time it's on the facial or the buccal surface. So the palatal is a great place to access. The other thing we need to remember, there's only 2 roots there. So you're not going to worry about root proximity. You've got plenty of room, and the bone is typically more organized in this area. So I find I've got great success. If you're right-handed, your contralateral side, so let's say that you're right-handed and the patient's coming in to treat IJ, I will just routinely give my stage 1 and my stage 2, just give it on the palate. One other quick technique that I do is if I have a little one who's having a tough time, even before I do anything, I've learned to tap their face a little bit. And I find that because sometimes, it's going to take a little bit of time to give the whole injection. It just allows them to worry about something else. So just kind of gentle tapping on the outside of the face, sometimes I find is soothing for the patient. If we go to the next slide, I'll show you an example. And these come from one of my dear friends and KOLs there, Paul Bond. And you can see he's giving this on the lingual surface. If you look, that patient had a large infection on the E there. And so trying to inject in that area, you just don't have organized bone. You're going to have a hard time getting that patient numb. And it's no different. Finger position, hand position is exactly the same, and just give it on the lingual. Let me go to the next slide. And it's the same thing for the upper arch is, he chose to come a little bit more vertically. The only issue with that, and what I do want you to be careful of, is it's easy in that stage 1, as you're giving that drop by drop anesthetic, to press apically and have the needle touch the bone before they're fully numb. So I would say if you're new to this, I would try to go more in a horizontal direction for your stage 1. But as far as great access, this is absolutely perfect. So the point is, just do it. Just do it.
All right. Next thing I'm going to tackle is what is the difference in drive and cruise? And I was watching the poll come up. Chris, I can't remember what the answers were. I think more people are in drive than cruise is what I think the poll said. So let's talk about what that even means with the devices. And, I know that all of us drive these cars because all of our patients think this is what we drive on the daily. So just think of it like how you would drive your car, right? So if we are in drive mode, it is our foot is on the pedal. When we are using our rheostat, our handpieces, we are in drive mode. When our foot is on the pedal, the burr is turning. When we take our foot off the pedal, the burr stops turning. And that is what drive mode, that's the same thing with these devices. If your foot's flushed down on the pedal, anesthetic is coming out. You take your foot off, anesthetic is no longer being delivered. But if you want to use cruise mode, that is a tap method. So you tap the pedal, you take your foot off of it, and the anesthetic keeps delivering. The light keeps flashing. When the light's flashing, that means fluid is flowing from the device. I used to be a drive person. now I'm a cruise person because I don't like to keep my foot on the pedal. I like to maybe hold the device, especially if the kid's good. I can scroll over to the laptop and I can look at an x-ray, or I can be doing something else without having to sit there with my foot locked on that pedal. It is a preference. And I will also tell you that these are little mini computers, and a lot of people touch them in our office throughout the day, assembling them, taking them apart. 4 doctors, 17 assistants, and sometimes they get moved out of cruise to drive or drive to cruise. And so sometimes I have to like figure out when I go into the room what it's in, and I don't really care. And once you get used to them, you don't really care. But if I have a preference, I do like cruise mode. So, live with drive for a while is what I would tell you, because that's what you're the most used to. That's what your hand pieces are there in drive mode, your rheostats in drive mode. If you're in cruise mode and you forget you're in cruise mode and you cap the needle back and you put it on the counter and you finish your treatment, this cute little situation happens and all your anesthetic flows into the cap of the needle and your assistant then gets to deal with that. So just do remember, if you are in cruise mode, to remember to make sure you're untapping it so that it's not sitting on the counter thinking it's numbing the counter.
Okay, and you include, perfect. There's just some suggestions on here of some little things that I think are important, and everyone's going to come up with their own lexicon and how to describe this. Ann already mentioned that she's going to call it, the thermometer or your magic wand. You're going to come up with whatever you're going to use in your office. One of the things that's important to me is that, yes, we all like technology, but parents, I think, and I don't blame them, they don't want necessarily new things tried out on their child, right? So I've learned how I talk about these devices. And at first I was really excited and said, I have this new thing I want to, use to numb your child. And sometimes the parents' eyes would get, pretty wide because I was excited about it. And so I discuss things differently now. And what I tell them is that I'm going to use the same type of numbing medication, the same exact numbing medication that I've always used, but this is a digital pump. And that's just a term that I came up with, and parents understand that, right? And it allows them to kind of understand what we're doing. But I think it's important to let them know this is the same local anesthetic drug that we've always used. For those of you that are new, I've had 2 experiences where when I first got the devices in the first month, a patient had come in and I'd use a traditional syringe on one side and given the patient a block. And when he came back the second time, I used my Soul Inner Sleeper 1. And I had 2 parents, I think, almost jump into the chair or try to knock me over because I just started treatment right away, right after I finished stage 2, and they didn't think that I was waiting enough time. So you may want to talk to your parents and just let them know that, we're going to be using this digital pump. And one of the great things is as soon as I finish and put it down, we can go ahead and start treatment right away. As far as eating and drinking, typically what I do in my office now, it used to be, hey, you've got to wait a certain amount of time, wait an hour for the lip and tongue for the numbness to go away. And most of the time now, I just tell them they can return to normal activity. I may tell them, you may have a little soreness like you would for any filling. We may give them instructions for if it's an extraction, but as far as post-op, it's a whole lot easier. And do you do the same thing in your practice? Do you give them the same, just let them go ahead and eat and drink right away, or do you let them? Yeah, you're on your mute. Yeah. So it's nice. You don't have to tell them, especially these kids. I find these appointments before lunch where parents think their children are going to starve because, they don't have time to go run them to get a smoothie or something. They can just go back to normal diet. I do want to point out these brochures that NuSmile came out with. And these aren't something just they wrote. They pooled a fair amount of us that use these devices on a daily basis. And I think it's a great summary, and we have them in the operatories. One of the things that you can think about as well is if you're big into establishing internal referrals in your practice, take one of these devices and then, you can paperclip whatever handout or whatever card you give for internal referrals. I feel sometimes icky asking for that. So it's a nice way of, hey, this is great. This is what we've used for your child today. And if you want to put that internal referral card on this, Some doctors have come up with something on their wall. Another suggestion, we do this for all of the handouts in my office, not for the brochures. Brochures we give to the patients, but for all our other brochures and information about crowns and cementations, things we have in a QR code. So they're just saved in a directory, and there's a QR code on the wall, and the parent can just scan the QR code and then just download immediately if you write your own information there. Okay, one quick point I want to make about scheduling efficiency, and this isn't really specific to these devices, is people ask all the time, well, do I need to change the way I schedule? And the answer is no. The answer is no. Yes, you can give local and start right away, but there's nothing stopping you from giving your injection, going to do a couple ops or a couple recalls and come back. But in general, when I teach practice management, especially when it comes to op, this is just something that I think is a good idea for anybody to do, especially if you have new staff or new devices or new procedure in your office, is take the time to do one of these time scheduling reviews. And so basically what we do is we just print these out. You can take a screen print of this and you write down what they were coming in for, what time they arrived, all the things that you would normally do in that appointment, and what's the total procedure time. Especially, we'll do this if you have a new associate in your practice. And what this allows you to do is really make sure that the time that you're blocking for that procedure is accurate. You don't want it too short. We don't want it too long. I don't want you to go overtime, but I also don't want you to schedule an hour if you're doing procedures that take a half an hour. So again, this isn't specific to these devices, but anytime I have something new in my practice, this is an exercise that we go through. And I find it incredibly helpful both to keep the schedule going on time, but also making sure that you're efficient in the time you have. And I find that people have done this. They're actually adding 1 to 2 appointments during the day in their restorative column because they actually know truly how long each one of these procedures take.
All right, I want to tackle this one because this does come up quite a bit. Josh kind of touched on it about a few reasons why your patient can be experiencing discomfort, and that's when the numbness is just, it's wearing off before the kid gets out of the office. We've got a shorter duration of the numbness, and they're feeling the discomfort of the treatment. And in our heads, we're thinking, oh my God, I did something. It was my fault. It's this new device and I've caused the problem. And when in reality, probably all kids are a little sore afterwards. We're just seeing it a lot sooner. Another reason that can be is that when we're on this learning curve, we are stabbing our patient in that same location, more than one time as we're trying to get into that bone, and that can make it sore. Another reason can be that we're over delivering, especially in stage 1. If we are giving way too much anesthetic in stage 1 and we're pressed up against that bone, we can cause an ischemia, especially if we're using the less concentrated, the 1 to 100. So, that is something that can happen. If you've been on the Facebook page, people have no problem posting which I love about it. They'll post like, what is this? What did I do? Like, help me. Like, I don't want to do this again. What's going on? And to be honest, this really isn't very uncomfortable to a patient. I would equate that, what we're looking at right there, to almost what gums can kind of look like when you're, have to be aggressive prepping a stainless steel crown.
And can I make the point though that this is very rare? I've never had, tissue ischemia here.
You will tomorrow.
Yeah, I will tomorrow because I said it. But I don't want you to, it's something you need to watch for, but this is not something that comes up a lot. We get asked about it, so we have to cover it, but I wouldn't be overly concerned about this. And this is, again, another reason why to use 1 to 200,000. You just have less of a chance of ischemia there.
Yes. And this, I would say that this probably is more the common thing, is like you are just learning your angulation and how far to go and getting comfortable with the devices, and you're in the PDL, bro. You got to like back it off. That hurts. Like giving any type of a PDL injection and you're blowing up that ligament away from the tooth, that's going to be sore. That is definitely going to be sore afterwards.
Okay, this is my I think my closer.
Favorite slide.
My favorite slide. The reason why this is my favorite is to me, this is summarizing all the things that I need to do, because I've had way too many times at the beginning where I picked up, let's say I picked up my SOAN and got my positioning and everything was great. And I got my hands exactly where it needed to go. And the needle goes into the papillary triangle and guess what? It's not on, right? Or I look and the wrong anesthetics in it. Or I didn't check the x-ray and realize that there's, there's a parulus or there's a parl, and I should have gone from the lingual. So this is a little mantra that I say in my head, and I literally do this every single time to make sure that everything's ready to go. So number one, is it on? Now, we don't have to worry about this with your sleeper one, but your SOAN, you want to make sure that when you pick it up, that the unit's on. You have to turn it on if it's hit standby, and that's a setting that you can dial in on your SOAN. But at default, standby time is 10 minutes. So that's going to give you 30 applications, 30 uses, full carb. So most of the time, or if you're using a half a carb, you've got 60. We just leave it on default. Okay. So power, is it on? Then number two, I'm going to check my radiograph. I'm going to look at my injection site. I'm going to talk to the parent. I'm going to talk to the child, make sure everybody's on the same page. I'm ready to go. Then pedal. The last thing I want to do is go have perfect position on stage one and then realize I can't find my pedal. Now, some people like the pedal on their left. Some people like the pedal on their right. The one thing I will tell you is because these do use radio frequency, we have had some docs, we have these new huge, like 8X chairs that are 2 feet of metal and have cushions. And if it's the pedal is not talking to the unit, it may be your pedal's shoved way underneath and you're just not getting that radio frequency. It doesn't happen very often, but just make sure your pedal's in the right position. Not only is it close to you, but can your foot get to the first stage, that small pedal, and the large pedal equally, okay? And then I want to get my position down, right? Is my patient in the right position? Am I in the right position? And then I can go ahead and deliver my local. So power, plan, pedal, and position.
All right. So what are some key tips to help me make the switch to electronic anesthesia? The first one is give your credit card to NuSmile and buy these units.
And by the way, we don't get a kickback on you buying these. They don't send us an Amazon gift card for everybody that buys one. We have nothing.
No, I wish that happened, but we do get cool swag. I do have a very cool vest that I'm wearing tonight, actually.
Oh, I got sunglasses. That's what I got. Thanks.
I just want to see everybody enjoy being a pediatric dentist. How many courses are there out there now? Christ, I taught one of them on burnout and anxiety. I mean, this reduces anxiety so much for us and for our patient. What are our patients scared of? That we're going to hurt them. What are the parents scared of? We're going to hurt their kid. What are we worried about? That we're going to hurt the kid. So, this is like totally taken our level of stress down so much. And I want to see that for everybody on this webinar tonight. Other things I want to tell you is be patient. This was the hard one for me because I want to back out. I want to be like, I can't get in the bone. Screw it. Give me my traditional syringe. And you have to be patient. You have to live with the device. You have to be patient and work at getting it into the bone, and just don't give up. Don't put it back into the box. And you have to keep practicing. It's going to take practice. You're going to, like Josh said, you're going to bend some needles. You're going to have some issues. And if you just sit there in silence and suffer in silence, you are going to put it back in the box and go back to doing things the way that you were. Another thing that'll help you is joining the Facebook group. You do not have to have the devices to join the group. Just here's the QR code, or just, search it on Facebook. Excellent place to learn. I would say that all of us KOLs are in there to help out NuSmile. We want to help NuSmile with this. We're the ones using the devices, so we do try to give input, but I probably learn more than I teach in that group. I'm always reading the comments and going like, I didn't think about that. And then training. We've got amazing people like Chris on the call that can help you out. And we have Jordan on the call. Jordan, we got our picture together, bro, right there. You and me, finally. Yep, and about time. And then Erin. Erin is great. Erin, the thing I love to say about Erin is Erin has a teacher's heart. She was a school teacher before this, so she really knows how to communicate and get give examples to us for what to do with these devices. So again, just great, amazing human beings that want to help us learn. And then training. When I got trained in November of 2023. I run the study club here in Greenville, so I got all the pediatric dentists together and we trained everybody. And over half, I mean, I can't use it as a marketing tool anymore because probably like 75% of pediatric dentists where I live now all have the devices, which I think is amazing. And we're all doing excellent things for our patients. But let's say that you're on this call and you have a large group practice or you have more than one location. NuSmile is very open to working with you and, doing a Zoom call, getting someone like Josh or myself to Zoom with you in your practice and get your team members on there, get them on board with this. We're happy to do that. And sometimes depending on what size group you are, or if you buy the units, NuSmile will fly to you. Chris and them will fly out to you and help you in person to get these devices in use.
And one quick point is, last year post APD, I believe they sold out. Was there a waiting list last year after? Chris, you'll know the answer to that.
We did. Yeah, we had a back order wait list.
Yeah, there was a back order. So and I never want to be salesy and push anybody to buying one. But if you're thinking about it, I know a lot of people wait for some deal at the APD. I would, if you want this now and you want to start integrating it, I would order it tomorrow. Again, I don't want to push anybody, but I just don't want to see you wait to the APD and then you're on a waiting list because they sell very quickly right after that meeting or during the meeting.
So I just want to give you some final pointers here as we wrap this up. Thank you guys so much for staying with us tonight. The first thing I just want to say is don't overthink this. Just don't overthink it. Just pick it up, use it. You're not going to, no one's getting 1-star Google reviews. No one's going to the hospital. No one's dying. Like it's not, just don't overthink it. Don't get out over your skis about it. Just use the device. Do the training though. Open the manual, read it. Don't try to be some hero about it. You do want to understand the devices. The second thing I want to say is don't reinvent the wheel. Just if somebody has done this before you, call that person. If there's something you can learn from someone else, just don't go cowboy and just don't reinvent the wheel. Everything is available for you and we can help you figure these things out. If you really, really struggle, this is very helpful because if you just post online, well, this is what's happening. I can't get through. I was doing great. And then 3 months later, I can't get through the bone. I'm having all these patients, I can't get through the bone, or I'm having all these patients and they're hurting, or I can't get tooth, blah, 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 numb. It's super helpful if you can take a video, ask the parent if you can take a video, bless you, Chris, and share it. Share it on the Facebook page or share it with one of us or share it with somebody from NuSmile and we'll give you our input. A lot of us will give you input to, maybe we can, troubleshoot what issues that you are having. And then lastly, these are all the amazing people who partner with NuSmile, teaching everything from stainless steel crowns to BioFlex to Zerks to MTA to these devices to the scanners. And we want to help you. So just please, like I said, just please don't suffer in silence. If you know any of these people on here, reach out to them. Even if you don't, now you know me and you know Josh. So reach out to us. If you see us in Denver, if you see me and you do not know me, you better knock me down in a hallway and be like, hello, I want to meet you. I was on the call. You helped me. You sucked, whatever it was. I want to meet you in Denver. So please, I'm never too busy to meet people. I love meeting and making new friends.
And can you go back one quick slide? One thing I want to point out are the webinars. We don't have them just for NuSmile Tech. One of the best webinars that I have seen the last couple of years, Patrick Ruck there gave a webinar for NuSmile on bioactives. And it was amazing. My hand was cramped. I was writing so many things down. So, and continue tuning into these webinars. We had Paul Bond there give the mastering last time. So go back, look at the other. If you're new, go back to the webinars and look and do all the intro. Some of this may have been over your head tonight because we didn't go through the basics. Trust me, there's 5 or 6 or 7 webinars there going over the basics, right? And then go on to NuSmile's page and look at the other webinars that are available for you.
support, again, just please reach out to NuSmile. They want, what they don't want is you to buy these devices and then talk crap about it because you didn't use it and it didn't work and all this. Like, you have to give it a chance and you have to ask for help when you need it.
And please, if you have questions, you're struggling, post to our NuSmile, the So In Sleeper One Facebook group. If you post to IPEDO and people don't know about the devices and you're struggling with something, it's usually just user error, and we really want to make sure people understand how easy these are to use. So send it to us directly, put it on our Facebook SON group, but just keep it there because that's where you're going to get the most help.
For sure. And then NuSmile does do lots of great hands-on courses, and the hands-on course is usually on a Saturday, and it's lecture style and it's hands-on. You have your own station, you have a handpiece, you have dentiforms. It is kind of like you sweat a little. It's kind of like being back in dental school, but you get to practice all these different techniques and use all these amazing materials without a mom standing over your shoulder, without a moving target. And I really am thankful that NuSmile moves them around. They're not, they're stationed in Houston. They could have all of them in Houston. We could all have to fly to Houston, but they do a really good job of getting out on the road and getting into areas where all of us live. So these are the next ones that are coming up. I'll be teaching in Charleston. Dr. Megan and Dr. Brian Richards will be teaching in Los Angeles. If you like one of us or don't like one of us, you can go to the website and you can see who is teaching in all the different locations that are coming up. And then we have two more coming up.
I'll be in Newburgh.
Oh, you'll be in Newburgh. Okay, very good. I will be in Fort Lauderdale, going out a couple days early to maybe get some sun in November. I don't know. And then we have Boston to wrap up the end of the year. And we just want to say thanks to everybody for hanging in here with us tonight. I know it is the end of the school year and people have a lot of stuff going on, and it's the middle of the week, and we're all trying to make it to the finish line. So thank you. Josh and I will stay on here. We'd love to take some questions from you. And like I said, definitely hope we get to see a good bit of you in Denver.
Thanks, guys. Great job.
Everybody.
We do have quite a few questions, so we'll go ahead and get started. Some really good ones, basic ones, and we'll tackle all of them as quickly as we can. So first one is, how do you sterilize the units? So we can absolutely touch on that. Aaron, Jordan, would you guys like to chime in on that?
I actually like the way Josh says it. I'll quote him here. Open up the user manual and the instructions are there, but standard autoclave cycle for the containers. One thing to note, when you start to see some cracking, that does not mean they're, done. You're going to want to wait till it looks almost like shattered glass, like cracking all the way through.
Not cracking of the unit, cracking of just that little piece that holds the anesthetic.
Yes, good catch, Ann. Yeah. Of the plastic containers that hold the anesthetic needle screws into, not the handpiece.
Yeah, so that's the only thing. And then the unit itself, Aaron, you want to say like how you wipe that down or what we recommend?
So the unit itself, you're going to wipe the actual unit with a cavity wipe or any wipe that you typically use that doesn't contain alcohol. If you use an alcohol wipe, it will dry out the plastic over time. And then avoid the base, because as you can see, those are metal contact points, and the contact points in the charging base are metal. And so if you put metal on metal and add electricity, that's not a good thing. So just wipe the top part, avoid the base.
One other point with your unit, you don't want to leave it loaded, ready to go for your sew-in the actual base itself. So with your local anesthetic and your needle, there's always a possibility that some of that local, I haven't seen it, but it's possible that some of that local, you can have a problem with, your actual carpio of local anesthetic, and you don't want it sitting vertically and dripping back into the electronics of that unit. So charge it, but then take it off the charger once you load your cartridge and your local anesthetic and your needle.
Awesome.
And follow directions. You get a manual, you open it, give it to your team, and it will tell them what to do. Not like just put the cartridges in cold sterile and have chemicals eat them for hours at a time and don't actually put them in the autoclave. Directions are very easy to follow. Print them out, put them in your sterilization area.
Right, exactly. Next question is they are referencing some specific slides here, and if you wouldn't mind just kind of going back here, but the question is, can you point to exactly where in the papilla you want to inject for stage 1?
That was my slide, so I could talk about that. So in your brain, make that papilla a triangle. Okay, and at the tip of that triangle down to the base, you're going to cut that in half, right? So that line is the middle of your papillary triangle. Don't overthink this, but there we go. One more, please. There we go. What my goal is the very tip of that needle, I want to start injecting about a millimeter. I don't think you can see mine. Can you, Ann, can you move on the mouse kind of just lateral to where the papillary triangle, where you would enter actually on that photo? So if that's the middle, right, I'm going to go just about a millimeter mesial to the direct middle there. Exactly. And the reason for that is as you're injecting, what I don't want you to do is start at the very middle of that papillary triangle. And as you inject, your hand starts to slip and that needle gets closer and closer to the mesial of T, because the problem is that's the PDL, right? So if you start just lateral to that middle, then you're going to make sure that you're injecting. And remember that solution is the needle's just penetrating the tissue. The solution's got to go out from there, right? So you want to drop, in your mind's eye, think about dropping that drop. That drop's got to sit in the middle of that papillary triangle.
And the other thing I tell you is whoever is asking that question, go back and watch the intro webinars. There's great video footage of us like physically giving stage 1 and stage 2. I mean, probably at least 3, 4, 5 different examples in every single webinar, and probably in the masters as well. That's a great way to learn.
The other tip here is when you're giving your stage 1, don't think about stabbing. Think about just flexing. That needle, if you look, I've looked at plenty of them under the microscope, that needle is so sharp that all you need to do is position the needle and just slightly press. Just give it a little flex, and that needle is going to pass through the soft tissue, and then you're not going to worry about pressing too hard and bumping into bone.
Next question has to do with the slide about palatal and lingual injections. Can you re-show that slide, please? And maybe just kind of talk through it quickly again.
Again, don't overthink it. You're doing all the same steps. You're just giving it on the palatal surface. So if I'm treating I and J, we can go back one. If I'm treating I and J, actually, no, we can go ahead. And if I'm treating I and J, all the steps are exactly the same. The only difference here is that where I differ a little bit, some of this just comes down to access. I like to give the first stage horizontally because I find it's a little bit easier to slip and push that needle too close to the bone if you give this vertically. I asked Dr. Prin that early on. I said, well, can't I just keep my needle in the same position the entire time? And you could, but again, the reason why we go horizontal is because you're less likely giving that stage 1 to bump into the bone. But besides giving on the palatal entering in the palatal surface, everything's exactly the same. There's not a difference. And I just find, yeah, go ahead.
I was just going to say, my comment would be, this is counterintuitive for me. I haven't given a palatal injection since dental school, to be perfectly honest with you. So when I felt like if I'm going to teach this, I need to do all these things. And so I practiced on kids that were under GA. And because Josh is right, that tissue is a lot tighter to the bone on the palate, and it's a lot thinner. So you're going to you could hit that PDL a lot quicker than you could on the buccal. So I practiced my positioning, and I practiced how much I would give when I had a kid fully asleep without a parent over my shoulder. That's what I'd recommend.
Next question is, how do you switch between cruise and drive on the SOAN? So before we get into that, I do want to reiterate, the cruise and drive feature is only on the SOAN. You can't change that on the Sleeper one. Jordan, Aaron, would you guys mind just quick walkthrough of that?
Yeah, I'll do it. So if you're on the Facebook page, I did make a video about how to change it from cruise to drive. So if you think yours has gotten switched one way or the other, which it happens, and I'll touch on that very briefly, but then you can go on the website and on the Facebook page and you can see how to change it, or at least check it to make sure that that's not what's going on, or get a hold of us and we'll figure it out. So it comes in cruise mode when you get it out of the package. If you're buying a brand new unit, it comes in cruise mode. If you want to change it to drive, so remember, cruise is just like cruise with a car. You would press the button, so you would press the foot pedal and it would start, and then your foot's free to do whatever you want, and then you would press it again to stop. Drive, again, is just like driving a car, so you're holding down to go, and then you're letting go to stop. So if you want to change it to drive, you hold down on the triangle. There's a triangle button. Hold down on the triangle button, and you're going to hear one beep, and then you're going to hear a second beep, and you'll see 4 green lights. Then you're going to press on the outer foot pedal once, and you'll see the light is lit up. If you're on the second light, that's drive. First light is cruise, so you just toggle through by quickly pressing and releasing the triangle. So that is drive, and toggle back, that is cruise. I like to teach it in drive. That's what most doctors prefer, to be honest. So I keep mine in drive. So once it gets there, just let it time out, and then you're in drive. And the way to test that, do you want me to tell you how to test it really quick? So if you're on here and you have one and you wanted to see if you're in cruise or drive, if you're in drive, you would hold down on the foot pedal and your light should be blinking. And when you let go, it should stop blinking, because blinking means active delivery. So it'll stop actively delivering.
Awesome. Thanks, Erin. Next question is, if you're in drive mode, I think they meant delivery mode, specifically in stage 2, and you see the 3 lights. When you say give it a few moments, do you mean to let up on the pedal?
No, don't let up on the pedal. Try to hang in there, because like Josh was saying, every time you let up on the pedal and put your foot back down, you're resetting the speed and the cadence of the anesthetic. So give the device a minute to figure it out first, and not a minute. I don't mean a minute. I'm using that like it's not a minute. It's a couple seconds maybe.
And then
do you recommend
to back out a little bit or twist, or what do you do if you're worried that the unit's starting to get occluded?
I hang with it for a couple seconds, and if it doesn't, it usually corrects itself, and then I will just back up a little bit and see because maybe there is something blocking it, and if I back up a little bit, it'll give enough pressure to get out whatever's in the lumen of the needle and get going again.
Awesome. Thank you. They may have seen this on the Facebook page, but the question is, Articaine. The question was that Articaine isn't approved by the FDA for patients under 4. Is that something y'all are sticking to?
Yeah, so I'll touch on that one. So the thing we need to remember is when the FDA clears a drug for use, they're clearing the drug for use. The IFUs, all of that instruction that it comes with, that's not something that they're clearing. And so when you have a DR in front of your name, you got to do whatever you want. And so when the studies were done with Septicaine, they just didn't have a bunch of parents that would volunteer their children under the age of 4 to use Septicaine on. And you're absolutely fine doing it. It's not that it's not, the FDA says you can't, it's just not included in the initial studies. But especially now, because I don't know what the percentage is of pediatric dentists that have these units, but it's really high. I mean, I was just at a meeting, and I think there was 40% in the room of pediatric dentists that had these, and everybody's using Septicaine every single day. So you're absolutely fine to use Septicaine. You're not going to have an issue.
And the back end of that same study that Josh is referencing, the age group was from 4 to 70. So you would also have to say, well, gosh, people over 70, it's not FDA doesn't approve it in people over 70. It's just because people over 70 weren't in the study.
The other thing I think to remember is I would be more worried about giving Septicaine as a block, not because of, the nerve toxicity, is if you're giving that, just pushing down the syringe, it's very easy to give quite a bit, right? This is such an exact method. You're giving this drop by drop. So unlike a syringe where it's easy just to deliver the whole thing and give too much, that's impossible for how slowly and accurately that you're giving the local. You're watching that plunger slowly move. So you're not going to over deliver.
Next question is, do you recommend ibuprofen after treatment and after extractions?
I don't. I heard Josh.
Yeah.
I heard Josh say that he does. We don't. I
do that if I think it's going to be. It has nothing. I think the point has nothing to do with the local anesthetic. It has to do with the patient and their comfort. Ann said at the very beginning, don't overthink this. When you're giving an infiltration, you were giving intraosseous eventually, right? Because that fluid is moving through the cortical plate down into the cancellous bone. So don't overthink this. It would just be related to if you think your patient could, benefit from having pain meds on board after your procedure. That's what it comes down to. It's just because this wears off a little bit sooner, can wear off sooner, you're hearing about it earlier. So you may want to think about giving Motrin or Tylenol. Actually, I think it's great that I may hear about it earlier because I may decide if I need to, offer to give Motrin or Tylenol, but it's really procedure based.
Next question is, I am comfortable getting most patients numb for restorative when taking primary and permanent teeth. However, patients tend to react and be uncomfortable when I've tried it for extractions. Am I not giving enough anesthetic perhaps? Is half a carp enough?
Good.
I mean, I don't know if half a carp's enough because I don't know which tooth it is. I don't know how old the patient is. I mean, maybe half a carp isn't enough on a 12-year-old that's playing wide receiver on the varsity team. He's playing up. It may not be enough for that kid, but it may be enough for the 4-year-old. I just feel like you got to read the room, just like you have to do with traditional anesthetic. You have to know, like, how much do you have to give? How much work do you have to do? And what's the situation? Is it a hot tooth? Is it not a hot tooth? I would say if you feel like that's your hiccup right now, I would err on the side of too much. If you don't think half's enough, give a full carpio. I mean, we're not overdosing anybody on a carpio anesthetic. So give more until your comfort level backs down or until you feel like you don't need a full carpio would be my answer.
The other thing with that is that patient, if you're taking out a primary or permanent tooth because it's infected, you need to make sure you're delivering in an area of organized bone. And if you're giving your intraosseous injection, let's say on the buccal, and there's a big fistula there, that you're going to be injecting in an area where it's not going to get close to the apex of the tooth. That's what you think about giving on the contralateral side. Give it on the lingual.
All righty. Excuse me. Next question is, if you numb mesial and distal to a tooth, do you need to do stage 1 for both?
The answer is yes. Because you want that periosteum numb before you drive a needle through it into the cancellous bone.
I know you touched on this, but on maxillary second molar primary tooth extractions with a longer palatal root, do you need to numb on the palatal too?
Think about that vessel. Right? Yeah. Once you get through the bone on either side and you get into that cancellous bone, it doesn't matter. You don't need to give, accessory injections.
Next question is, I haven't been using my SOAN for abscess primary teeth. Is lingual the best way to use SOAN for those teeth? Thank you.
I'm not sure it's the best way to use it. First thing I would do is pull out my radiographs. I would see where I have organized bone. If I have organized bone, a tooth behind it or a tooth in front of it, that is where I'm going first. I'm not going to try to fight the demon tongue on the lingual if I don't have to. I'm going to try to find organized bone on the buccal first. Josh?
Yeah, I mean, exactly. And if you need to think about it, give some mesial, give some distal to that tooth. But Ann's point of the radiograph, it's just like we don't do a pulp before looking at a PA, right? You're not going to treat that patient without looking at the radiograph, and then you make an informed decision about it, right? And it could be that on on the mesoroots resorbing. And if I see that, then I may choose to, give it on the distal because I know there's still a full, intact nerve in that area.
Next question is, if you are doing restorations on 7 through 10, would you only give IO at the midline?
So I treat a lot of permanent anterior teeth for aesthetics. And I tell you, this is one time where not one time, but I like to use my unit and give a PDL there, just a normal infiltration. One of the reasons is if I'm doing, aesthetic case, I don't want to have the risk of having a little excess bleeding or give near the papilla and have a little bit of tissue reaction of the papilla swell, especially if I'm closing a black triangle or doing a peg lateral. So I tend to, and the bone is so thin there, I tend to use the unit and just give a standard infiltration with it. And the patient's the pain is such limited because that needle is so sharp. So I tend to not give IOs in the anterior if I'm doing composites there. I'm just using it to give a PDL. You can, absolutely fine. I just choose, I don't feel like I need to. Again, the bone's so thin in that area, it perfuses quickly.
I do. I go right between 8 and 9 and fix all the interproximals between 7 and 10, which I want to vomit when that's on my schedule. But if I have to do it, I do it.
Next question is, what causes the patient to feel that their cheek is numb after using the Soman?
I'm not sure why someone would feel that. My thought would be if they're having any, the patient's telling you that their lip or their skin is numb, either you dribbled a lot of it out on stage 1 or stage 2. Sometimes when you're pulling the needle out on stage 2, it has a lot of back pressure and it sprays everywhere. So definitely have your assistants very close by and in proximity to what you're doing. That could be part of it. And the second part of it would be what we call a paresthesia. And that's where you're learning the device and you're kind of, you're almost giving a little bit of an infiltration accidentally, and it would cause a paresthesia in the area because it would numb different branches of the nerve. And kids are weird. Kids will tell you stuff and you're like, okay, you're lying.
Like it's hurting when you're holding your handpiece in the air.
Yes.
Next question's a good one. Are you having your hygienist give these injections? I've heard it differs per state. I did call my state dental board and they couldn't give me an answer.
Because they don't freaking know anything. Sorry, that was awful. That was so awful. I'm going to sit down. Josh.
I don't have hygienists in my practice, but there should be no difference in a standard syringe versus electronic delivery device. If that practitioner is licensed and it's legal for them in your state to give local anesthetic, I don't see the reason why they couldn't use one of these devices. I mean, don't quote me on that, but it should not be any different. Remember, the business end is the same. It's still a needle. You're still putting it into the body. You're still giving a local anesthetic. Whether it's manual, electronic should not make a difference.
Aaron, do you have anything to add to that? I know you did some training with some offices that the state, they actually did use it.
The device?
Yeah.
Sorry. No, I'm sorry. I don't have anything to add.
Okay.
So when we went at the CSPD, which was held in Seattle last month, we did some training, and a big office, 8 practice office, had 2 hygienists. They have more than 2 hygienists in the practice, but we did hands-on training at the class, and they both used it, and they were blown away. So I don't. To Josh's point, as far as I know, and as far as NuSmile knows, we have not heard of any state putting the hammer down on this and saying this is some fancy thing, and we're not going to let hygienists use it.
Yeah, no, and actually, yes, the first office that we went to, they have a restorative hygienist is what her title was. And she does all of their, that's all she does all day is go door to door injecting before the dentist comes in. And she loved it. And yeah, there was nothing stopping her from using it.
Yeah. Yeah, I mean, I guess it really does just depend on the state, but there might be some limitations on different states. But I would say, generally speaking, if they're using it for standard injections, if they're doing standard injections, then the same rules apply. So
Although I feel if they can give a block, I mean, this is way safer than giving a block. So, I mean,
correct.
yeah.
All right, and then save the best question for last. What is the difference between the SOAN and the Sleeper One?
The price. Boom. No, just kidding. That is a difference.
Two main things. I would say the first thing is the cord versus corded. So SOAN is cordless. Sleeper One is corded. And then the other thing is really just more of a user preference, but the indicator lights on the Sleeper One are 360 degrees around, so you can see it no matter how you hold the device. On the SOAN, it's on one side of the unit. Anything else you guys want to add?
I would say the other thing too is that I don't know what the dynamics of your practice are, but that SOAN is a way more intricate computer. It has a lot more buttons on the pedal and on the handle. And like Aaron was showing earlier, you can get it in the wrong mode, out of the mode. You can get it where it's stopping at a quarter carpule. And the quick sleeper is like
Not
intraosseous for dummies.
Sleeper One.
I mean, the sleeper one is like intraosseous for dummies. Like you just pick it up, put your foot on the pedal and go. There's no
Plug and play
about it. There's no
That's what I
assistant
have.
who's resetting it. It is way less of a chance of it getting out on the wrong setting.
And I think one thing I want to point out is, a lot of people will mention, well, they're worried about the patient grabbing the cord. And I've treated a lot of not uber cooperative children with it, and I'm not concerned about that. The way the cord is draped, you don't have it near their hands, right? It's up by their shoulder, because when you're using the device and you're holding things properly, that cord is nowhere near their hands. It's draped to the side of the patient. So they'd actually have to open their eyes, look to the side, find a cord. In my hands, it's not going to happen. So I am not concerned about that, nor have I had a close call whatsoever in thousands of injections with it.
I would agree with you. When I was making the decision to purchase it, I chose it because I was afraid of the cord. But now that I have one in my office, you're absolutely right. That cord like snakes behind you.
Next question is, there are a few times where I'm doing primary molars back to back, and I inject between the molars. I've had the patient feel pain or sensitivity when I'm drilling on the distal occlusal portion of the second primary molar. Any reason for this and suggestions to prevent this?
Yeah, I would say two. I mean, number one, did you give enough local to begin with? But I will tell you that for just back-to-back composites, I find, if I'm, for let's say S&T, I give a quarter carp and I'm fine with it, right? I rarely give more than that. I think what it comes down to often is angulation, right? You need to remember, even if you just injected into the papilla, but you did not, you weren't in the bone at all, if you wait enough time, that local is going to perfuse into the tooth, right? So if I find it's maybe positioning, that doctor may have gone too flat and actually come out the papilla on the other side, and the patient is getting some local effect, but they're not profoundly numb because they really have dumped most of it in the soft tissue. The other thing is you need to just look at your radiographs, and if you have a tooth, let's say that had their distal root that was resorbed, let's say the 6 resorbed the root. I mean, it is possible that you're not going to, if you're not getting numb there on the distal because of that, but I've just never had that happen.
And then the last question is more of a comment. Another good one. We'll save that one for the end as well. But great seminar. I'm taking mine out of the box tomorrow morning.
Oh, there you go.
For a second attempt. So I'll add to that. Make sure you guys do your onboardings with Jordan and or Aaron for our new users especially. gives you a great opportunity to troubleshoot and go over the basics, but really dive in as deep as you want. So if you haven't, the doctor that asked that question, if you haven't done that yet, please reach out to us so we can get you squared away.
And my suggestion when you do the onboarding is have some of your team members with you. Don't just be the one that has to learn it, understand it, and take the information back. If you can do it on the lunch hour with some of your team members, that is crucial.
Or don't defer to your team members to do the onboarding and don't do it yourself.
Right. Make sure you're doing it. That is the last question. We'll give it a few minutes just if anything else comes in. But again, hopefully we will see everybody in Denver next week. We're greatly looking forward to it. We're going to have a lot of experts and brains and everything else that are going to be inside that booth to answer all your questions and get some one-on-one hands-on experience for new users, experienced users, people that are still on the fence, just kind of unsure. It's definitely going to be a great opportunity. So hopefully we will see everybody in Denver next week, and be on the lookout for that email tomorrow. And yes, that's a good question as well. So all of these webinars are recorded. So we post them on the NuSmile website through our YouTube page. So you'll see this one on there probably by the end of the week, by Friday.
Chris, can you just let everybody know the days and times that Ann and I are going to be on the floor speaking? So if they want to ask questions in person, I mean, we'll probably be there other times, but just so they know.
Yeah.
Can you let Ann know when she's supposed to?
Yeah, let Ann know.
Yeah. And don't forget, you're speaking. You'll be there
10:30
Friday morning from 10:30 to 11:30. And Josh will be there from 11:30 to 12:30. And again, while Ann is speaking in the booth, in the NuSmile booth, Josh will also be speaking at the industry insight session through AAPD. I believe it's around booth 300 or something like that. It's a big booth. It's got 70 seats or something like that. So
Chris, what is that? I don't even know what that is, right? Josh, what are you doing? What is insight session? You're not talking just about this, right? You're talking about what?
Just about this.
Just about this. Oh, that's awesome.
Yeah. So we did have another question come in, guys. What if we bend the needle in the bone?
You're screwed. You're not screwed. It's going to happen.
Thanks.
Definitely part of the training. And that's what we want. That's where we want that to happen. Like if you're pressing wrong, or if you're in the long axis wrong, or you can't get through the bone, we'd rather see that needle bend than see that needle break. So if you bend the needle, it's going to happen. You unscrew the needle, you have other needles sitting on the counter, and you screw another needle in and you go.
Hypothetically, let's talk about if your needle broke. I would much rather have a needle break with an intraosseous injection than giving a block, right? You give a block and your needle breaks and you buried that needle, bad things happen and the pterygoid muscle will swallow it. If hypothetically, I mean, I've never broken a needle, but if you did, what do? That needle, trust me, is not going anywhere. You could probably send that patient home for a week and have them come back and it's still there. You grab a Howell plier and you remove it, right? It is in the bone. It is not going anywhere.
Yeah.
Awesome.
Question.
Well, I think the important thing to know, though, is these needles are designed for intraosseous injections. They're designed for this procedure.
They are designed to bend before they break. So
yeah.
You'll definitely have those needle bends in the beginning specifically. So definitely nothing wrong with that. So we're going to go ahead and call it, guys, unless anything else comes in. But appreciate everybody spending their Wednesday evening with us. And again, and Josh, thank you guys so much. And we will see, hopefully, everybody in Denver next week. Have a great rest of your week, everybody. Appreciate you guys being here.